Hi, everybody. Welcome to the Evidence-Based Design Journal Club. Sorry for the slight delay, but we're going to jump right in. For those of you who haven't joined us, really the purpose of the Journal Club is to create this community and engage folks in understanding the role of the built environment. I am Sheila Bosch, and I am an assistant professor at the University of Florida. And just thanks for coming today. You know, I would imagine that we all would agree that patients cannot be healthy and well cared for unless our staff members are well cared for. So today we have an opportunity to talk with the authors of the study that will, I want to get the exact name. Oh, well, let's see. We know that. There we go. Thank you. Demonstrating the effect of the built environment on staff health-related quality of life in ambulatory facilities. All right. Now, just a little bit of housekeeping. So we do have CEUs available, both EDAC and AIA. So in order to do that, you can get the files that you need up in the right. There's a Show My Media Library icon, and you can click on that where the arrow is pointing, and you'll have access to the AIA quiz and the EDAC form and today's presentation slides as well. And then to download a file, just click on the green arrow, and when you're finished, click the double right arrow in the top left corner of the media library, and then that will close. For the EDAC credit, complete the verification form and retain it for your records. And you'll need to submit that to CASA Worldwide at the time of your renewal. And for the AIA credit, you will need to complete the verification quiz and also purchase a CEU management fee for just $10 from the CHD store, and then submit that verification form to Shannon Reckline. So let me just tell you a little bit about how you can engage and become involved. This is the screen, and you'll see here that the chat feature is easy to use. I hope you'll find that. You just type into the chat box where that red arrow is pointing, and be sure that you chat your notes to all, so that everyone is able to see your comments. And just a reminder, feel free to jump in at any time and type in your questions, and we'll try to get to them during, but if we miss them, we'll try to get them at the end of the discussion. So thank you all. I'm very excited because today we have my good friend Deborah Wingler and Richard Hector as our guest authors. Just a little bit about them. Deborah has been an advocate for innovation in healthcare since 1998, and she holds a Master's of Science in Design in Healthcare and Healing Environments from the Herberger Institute for Design and the Arts from Arizona State University, and a Bachelor's of Science from Northern Arizona University. Her research currently focuses on bringing high-quality care to vulnerable populations and medically underserved communities within the ambulatory care environment throughout the United States and even internationally. She's very interested in understanding the impact of the built environment on the patient and staff experience for new and emerging models of care. And then Richard Hector, he is interested in global health and vulnerable populations as well. He completed his PhD in health services research with an outcomes cognate at UC Los Angeles with a Fulbright scholarship to Trinidad and Tobago. He was the first person to demonstrate the cross-cultural validity of the quality of well-being scale, which you'll hear more about in a minute. And he's a quantitative methodologist with an interest in cost-comparative effective analysis of environments, treatments, and behaviors that affect well-being. And Richard works for CVS Health and is a part-time lecturer at the University of Trinidad and Tobago. So thank you both for being here today.
Thank you for having us. We're really excited.
All right. Well, let's go ahead then and just jump right in. Just start with why did you even, do this study. And
Right.
and how did the two of you come to collaborate, actually?
Well, should we start there?
Yeah, let's start there. That's a great story.
It's just kind of like all great, I think, relationships that happen. It was really fortuitous. I was actually filling in for Adelante Healthcare's CEO, Aveen Satay-Tafoya, at a conference, and I was leading a roundtable just sharing with the people that were around the table what we had been doing in the built environment and how we were using the built environment to impact health outcomes within its population. And as I'm going through this pamphlet that we had put together and talking, all of a sudden a business card comes to me, and it's full of text. And I thought, oh, okay. And so I very politely said, well, thank you so much. We'll take comments and questions here in just a minute, but let's kind of go through the topic. And, just kind of graciously put my hand over the card, kept going, and within less than 3 minutes, another card comes full of text. And I said the same thing, just okay. And I really didn't, I was on my feet, didn't really have a chance to look at it. Finished out the round table, finished out the conference, was heading out and truly heading to another meeting and was actually late. So was trying to head out the door, and Richard came up, introduced himself, and said, I'd like to talk to you. I've got a great idea for a project. It would be so amazing. And like I said, I was kind of in go mode, and I said, that's great. Here's my card. Why don't you just send me the information? And really expected nothing more from that. And within, I think, Richard, if I'm not mistaken, it was under 30 minutes, he sent me in my inbox was a very detailed email expressing what his ideas were and what he would like. And I would say it took, that was kind of the first meeting. And Richard, I don't even remember now, a lot of happy hours and a lot of coffee shop meetings just to really begin to see if there really was a synergy, and if there was it feasible? Was it something we could do within the Adelante structure? So it
you've done a great. It's a really great study that you've done. So I'm looking forward to hearing more about it.
Thank you. Well, and as we go along, Richard and I are just gonna kind of go back and forth. I think one of the beauties of this study in the end for us is that even writing the manuscript, we could tell you what pieces and parts that we did, but the truth is we just worked really synchronously, side by side, and really, and there were real reasons for mandating that. We were really looking at combining two separate fields with using two really separate perspectives, and wanted to ensure that the message that we delivered was intact and synchronous using both realms. So just to get started, I think the slide in itself doesn't need a lot of explanation. You can see the numbers, but I think what we all can acknowledge is that we have definitely seen a shift from inpatient facilities to outpatient facilities and things being done in that arena. And on top of that, because of healthcare reform, we have seen a great insurgence of people that had been medically underserved prior. So just to kind of set the stage as we go, what we're talking about are federally qualified health centers. And so for anybody who's maybe not completely familiar with what a federally qualified health center is, they are really designed to reduce health disparities in medically underserved communities with vulnerable populations. And they have a focus on delivering preventative primary care with a focus on wellness and prevention, and doing so with a holistic approach. And then the next slide really starts to begin to understand how some of that interrelates. So because federally qualified health centers serve medically underserved and vulnerable populations, there is definitely a complexity to the patient that is different than what we see in maybe even just standard outpatient ambulatory care facilities. And then because of the nature of the complexity of the patient and the typical environments that you would have seen up to this point within those facilities, those healthcare organizations tend to struggle with continuity of care. And that is in losing staff due to, having retention issues, engagement, and absenteeism. And then I think for all of us to acknowledge that are in this chat today, there's just definitely a lack of research within ambulatory care environments as compared to inpatient environments. Okay. And not only that, then when you start talking about this patient population in particular, it's even less. So that in a nutshell is something of what drove this project overall. And just to kind of qualify, you can see this in the paper, but really what we were looking to do was determine the impact of the built environment on the health-related quality of life for community health center or federally qualified health center staff. And we're going to kind of expound upon this, but just so we can all have the same place to start with, we were really looking at two things. First of all, this is truly a pilot study, and our first question really was, is it even possible to measure the impact of design features within a federally qualified health center on the health-related quality of life for staff? And then, if we could successfully do that, would it be possible in any way to quantify the contribution of those design features on the health-related quality of life for staff?
In the public health realm, and I guess even in the clinical trial realm, the principle that we had was equipoise, and we really didn't know the answer one way or the other on where the questions would go. So we definitely had equipoise.
Yeah. And do you want to start, since you're already going, about our conceptual framework? Well, let me just say this. One of our first dilemmas, right, we're uniting kind of health services research and, healthcare design research or evidence-based design research, whatever you'd like to term it. The very first thing that became really obvious was that there was actually no conceptual framework available for us to look at in how to situate our study. And so the very first thing that we really needed to do was develop this conceptual framework for conducting research within the ambulatory care environment. So do you want to kind of start sharing about that, Richard?
Thank you. And doing that, you can always try to start from first principles and build it from the ground up. But often it's better to, instead of build from the ground up, to do a renovation. So we took the Ulrich model that has already been published in the literature in the built environment research field, and the Anderson behavioral model of healthcare utilization, which is in the public health field, and see how these two can be melded together and combined to take the best features of both, what we thought were the best features of both, and operationalize them in this research. And we followed the flow through from both models and many of the feedback loops in the models. And from speaking with experts and looking at the literature, we developed the arrows, which were actually pathways that were operationalized by getting factors and variables from the discussions with experts and the expertise that Deborah brought to the topic and the literature. So that explains the arrows. This framework guided the way we thought about approaching the research and which variables to put into the model that we discussed later on.
Right. And, I think, again, we would, acknowledge that we probably would love to be able to flesh out this model a little bit more and expound upon it. But for us, this was just really important to kind of get our bearings in regards to what we really, really wanted to look at. And I think one of the things to really highlight in this model as we go along is we really felt like we needed to acknowledge that not only does the built environment impact directly the health outcomes of patients, but it also affects the outcome for patients indirectly through staff.
That's true.
And also then to realize that in both of those regards, the impact of the built environment does pass through the population characteristics that we each individually have. And so for us, that was a really big thing to be able to put down on paper and to be able to really visibly see as to the connections we were looking at. So it's important for us to really just to kind of, again, set the stage to understand that when we're talking about health-related quality of life, according to the World Health Organization's definition, we are not merely talking about the absence or presence of disease. What we're really talking about is your ability to live life fully. And yes, that is physically, but that's also emotionally, mentally, spiritually, socially. So that's kind of the background as far as understanding health-related quality of life. And then I think when we look at the built environment, and this kind of goes back to our first slide, I think we can all acknowledge that we have made great strides in understanding kind of the interactions between the built environment and patients and staff, but also as much as we do know, there's so much that we still don't know. And so that is really, yeah, so that's really kind of what situated what we were trying to do. So let's talk about where this happened, because this makes it, I think, definitely hit home a little bit. So this study itself was conducted in 3 of Adelante Healthcare's facilities. If you have not heard about Adelante Healthcare, I would recommend that you go on the center's website. They are a Pebble partner, and that'll give you kind of an idea of what they have been doing, what they're doing, and a little bit about the organization and some of their projects.
Don't forget mention that the CEO was the Changemaker Award winner last year. So she's excellent.
Fabulous. And I have to tell you, straight up, this research study, everything that we have done could not happen without, Aveen's support and truly the organization's commitment to transparency. Because as you're going to see, not necessarily all of the findings that we have are glowing in some regards, but they are all incredibly meaningful and very helpful for this healthcare organization in being able to acknowledge them and take further steps in their quest. So Adelante Healthcare itself is a system of just this month now, 9 federally qualified health centers. So I apologize, you're only going to see 8 little dots there, but that was new as of the last few weeks. But they cover the Phoenix metropolitan area and the surrounding communities. This study was done in 3 of their sites, and we're going to go flip to that slide so it makes sense. These are the 3 sites that we looked at. It is their Phoenix site, their Surprise site, and their Mesa site. We termed those sites minimal, moderate, and comprehensive. So let's kind of take a minute and talk about why. So their Phoenix location was built in November of 2009. It was truly a remodel of an existing shopping mall area. It's obviously the smallest of the 3 facilities, and they did not have any intent of doing any evidence-based design within that facility when it was built. So while they did a few things just, to spiffy it up, it really is very much what you might think of as a very typical community health center. Since the time of its renovation, they have added, as you can see in that picture, some beautiful art on the walls for a positive distraction, and they've done some other minor modifications. But for the most part, it's somewhat of a very simple facility. However, the amount of patients that they pull through that facility is amazing. It's really incredible. And I do not have a cost per square foot on that renovation project because they were not keeping records like they are now of that. So that kind of gives you the basis for that. So the Surprise facility, their moderate facility, what we're terming moderate, that was the organization's first attempt really at incorporating evidence-based design into their interior features. And they really did, quite honestly, a fantastic job. So you can see that in the patient areas that from that image, and hopefully you can make it a little larger than I'm looking at it right now, but they do have an infusion of natural light on the patient side. They did put in colors and textures and finishes in the areas where the patients are in the waiting areas. They even have, which is not represented in that photo, an art gallery that runs all along one hallway that features community artwork. So beautiful facility, well done. However, again, it's a retrofit, a remodel from a kind of a strip mall. It has an incredibly long floor plate, and back of house was completely unable, in most regards, to get access to natural light. So the back of house, the staff areas are very vanilla, not really the color on the wall, really minimal access to natural light. And so you can see why we termed it moderate, although in part of it they were able to really accomplish what they wanted to, not necessarily all the way through. And then there's the Mesa facility, and that opened in November of 2012.
That's a beautiful facility.
It's beautiful, and we call it here comprehensive, but when I first described it to Richard, I called it locked and loaded. And and what is your term, Richard, for it?
Embassy Suites.
He calls it the Embassy Suites as community health care. And it is. It's really just, for those of you who've had a chance to see it, it's beautiful, just a phenomenal facility. And not only does it have pretty much everything you would want from an evidence-based design perspective, feature-wise, it is also Platinum LEED certified, so that means sustainability throughout. And there was incredible consideration given to incorporating lean processes into the plan and not just the floor plan and making sure that works, but into the operations as well. So that's kind of the facilities. Now, to mention Surprise, just so we have our bearings as we move along, the renovations for Surprise, for the interiors, was $70 a square foot. The renovation prices, or the building costs, I should say, for Mesa, which was not a renovation project, it was ground up. So the interiors for Mesa were $76 a square foot.
Wow, that's
outrageous.
Really hardly different at all.
Not much. So, and as you're going to see, that becomes even more important as we dial further down into the study. So this right here, I think it's pretty self-explanatory again, but this is our study design. We obviously did a cross-section observational pilot study. We had in total 105 participants. For the IEQ survey, we had already run that in Surprise and Mesa for another study. So we went ahead and ran that in Phoenix. And then for the quality of well-being survey that we're going to talk about, we randomly, they randomly agreed to participate, 10 participants from each site. So that's how that came.
Were you? I don't think you were able. Were you to match and know, like, if certain folks who took the IEQ survey who also took the quality of life or quality of well-being survey, right? I know it's difficult.
No, it really was, and I would say that when we look at it, that was definitely one of our, what we would consider one of our limitations. We would really like to see this done again, obviously on a larger scale, but we do feel as though it would be very helpful to be able to link the two surveys together per individual.
But in addition, both things were blinded in the fact that we had unique identifiers, but no way to link them back to the individuals. Because though we measured the individuals, the unit of analysis was the facility itself. So we didn't want to make conclusions or descriptions about the individuals, but about their reaction in the facility. So it's not quite as necessary to have. Linking them would be fine, but for the pilot study, it wasn't necessary to have the individuals linked to from the QWB interview linked to the IEQ interview. And
I will say this. When we did this, the total count for staff at Phoenix was 21. And you can see 20 of them answered the survey. Therefore, I think we are pretty certain that the majority of those 10 did take that survey.
That's an excellent response rate, Deborah.
So, thank you. Richard, do you want to go over pretty quickly the quality of well-being survey?
I'll be quick. It's a survey that was started way back when the World Health Organization challenged the scientific community to come up with a definition for health-related quality of life, or quality of life and health-related quality of life. It's had several iterations, and the version we used was finalized in 1975, 40 years ago. It has subsequently been tested and retested and for validity, internal and external validity in different populations. And as you mentioned earlier in my study of cross-cultural validity in Trinidad and Tobago, it has 14 items and 14 questions and follow-up probes. It takes about 5 to 10 minutes to be administered in person. It has many, many languages that it's been translated into and retranslated into English. The versions we offered to the respondents at this study were English and Spanish, although we had others available, but they just chose to use Spanish. It has, in the 14 items and follow-up probes, they're weighted, where the preference weights, or sometimes called utility weights, were developed, was randomized trial for San Diego, California, and I tested it subsequently in Trinidad and Tobago, and they still are the same over time and over geography. And it's generic in that it can be used across many different health conditions or diseases, and it produces a single summary score from 0 for dead or in equivalent state to 1 for perfect health. On average, working people usually score about 0.8.
And actually, Richard, if you could speak up maybe just a little bit louder, I think that would help folks to hear you better. But what I love about that survey is the fact that you can use it over just about any kind of health condition. That's remarkable. Often it's paired with either a disease-specific survey or a survey like the IEQ that delves more deeply into a particular arena. And so it was, so pairing it with the IEQ is a general way that people use it. Now, let's talk a little bit more about the IEQ survey. Is this the Berkeley Center for the Built Environment IEQ survey?
Yes, it is. And I think most of us are familiar with it, so I'm going to be really brief. It measures satisfaction and perceived productivity of staff over a range of criteria. In this case, we used the basic 7 criteria, which were air quality, thermal comfort, spatial layout, lighting, acoustics, office furnishings, and cleanliness. They do have additional modules pertaining to sustainability, but because those features are not throughout all 3 sites, we did not use those. And then we rate the criteria on a 7-point scale. So that's really that survey that we used. So this is the important part, right? What did we find out? So interestingly enough, these are just the quality of well-being scores, and I think these are really worth looking at and mentioning. What you can see here is that there is a difference between minimal and moderate, but it is not statistically significant. However, there is a significant difference between comprehensive and both moderate and minimal. And what I think is astounding in regards to this is exactly what we were seeing in the sites qualitatively. I could have told you qualitatively these jumps. And I think, again, that really is a testament to the sensitivity of the quality of well-being scale, but also that really what we have been seeing qualitatively is really, really happening. And then when we look at the results from the IEQ just by itself, we really are seeing, if you can remember that last slide, the same kind of a spread. Where Phoenix and Surprise are different, they're rated differently, there's just a huge difference in overall satisfaction with Mesa. Now, mind you, it's only $6 more a square foot from Surprise. So that's an amazing thing to look at. And what became really interesting is that when we looked at overall, then the perceived productivity, which is overall satisfaction with the workplace, our surprise brought up a little distance. And so that became really interesting for us, because with the long floor plate, I would have thought it might even go backwards. But for whatever reason, with some things that are in there, it brought up its score just a little bit in regards to productivity. So now, Richard, do you want to kind of talk about all the combined fun stuff?
Okay, but before we jump into the hard numbers, I wanted to mention a qualitative response we got. During the interview at one of the sites, a bit surprised, one of the respondents said that how much relaxed and how much she looked forward to coming to work because of the environment, rather than after she was dealing with some issues out of work, and how coming into work she just felt it lifted off her shoulders.
Well, we don't usually think about healthcare workers becoming less stressed while they're working. That's great.
And we had that, I think everyone we interviewed in Mesa said that, qualitatively. It was impressive.
Coming to work. Well, this slide, I'll go over it quickly. We did see from the previous slide, and this is also unadjusted, for these slides, the ages were not significant across the three sites. So it's not as if when Adelante hired people, they sent the healthy young people to Mesa and they sent the other people to Surprise and Phoenix. And as we looked at the different aspects of the slide, we see on the vertical axis is the QWB score, and we're looking at the design criteria on the horizontal axis grouped by site. And we see the basic structure we saw in the original slide, but as we looked at the individual ones, we see some things had more oomph than others. So we see that the turquoise to the right of the group, to the left side, on the left side of the group, it's significant. The difference was significant between the three sites, and there were other criteria that did not show a difference between, say, Phoenix and Mesa, but almost in every case, in every case, Surprise was different from Phoenix, but sometimes Mesa was different from Phoenix, but sometimes the comprehensive or Mesa was not always different from the moderate. And basically,
I'm sorry, just going to say for folks, if anyone can't see that, the bar he's referring to is color and texture, and I think that's really interesting since there's so much controversy about the impact of color and what colors elicit what sorts of responses, and I think that's just a really interesting finding because we do know color is important.
So going on through the results.
Well, really quickly here, and when we in the adjusted scores, we also looked at the R-square or the adjusted R-square, where we were adjusting for color and texture across the three sites. And we saw that the adjusted R-square is a measure really quickly of how much variance in the outcome variable is explained by the predictor or the independent variable. And color and texture got a 43.3%. It accounted for a huge amount of the variance.
Wow.
We were very surprised by the size of it, so we double-checked the numbers, and it was, as you saw in the paper, this was a simulation. So when it worked, it really, really worked well between the way the QWB and the IEQ moved together. And in a larger study with the responses for the both linked more closely, we'll see if it replicates this level of explanation. But this is a very impressive R-squared. In my field, we never see anything like this.
Good job, designer.
And then we really looked at the same thing, really. So these next few, just exactly like Richard had said, we just really started to kind of pull out some of the ones that we thought, we wanted to look at more. And natural light, again, just a huge number. And then we looked at noise level.
And although it didn't account for as much variance, because across the 3 sites, there was not a lot of difference in the noise level. There wasn't anyone working inside the building with a jackhammer that was going all day, to say. And so the 3 sites were very quiet to start with, and to see any changes at all is a testament to the amount of work that went into the comprehensive site.
I just want to remind folks, too, go ahead and feel free to chat in some of your questions if you have them as we're going along. So go ahead, continue, please.
Okay, the satisfaction with the noise level here that we're looking at is we're looking at the individual part of the Likert scale, again, on the horizontal axis, and on where we show the percent, and we show the QWB score as well. And looking at satisfaction with noise level, we see the QWB score does not track as precisely as there's no pattern to saying people who are dissatisfied are having a worse quality of health-related quality of life than people who are completely satisfied. It's a noisy relationship. Although the QWB score, the predictive variable, the Likert variable, explains a lot of the variance in the QWB score. When we were looking at productivity, again, we see it's a bit more noisy than when we were looking at satisfaction, but you see the same pattern repeated, in that the QWB score for perceived productivity, the MESA was the comprehensive site, was again many heads and shoulders above the other sites. And perceived productivity, as again, this is just replicating what we saw with satisfaction when we're looking at perceived productivity for the color and textures.
I think this electric light is really important to note. Again, we didn't see a huge difference between the minimal and moderate sites, but in the comprehensive sites, they are fully LED throughout. And so I think that this, definitely what we're seeing here, is a testament to that.
And I wonder if there's any, confounding by because it does have better natural light, which is going to sort of affect your perception of the electric light as well. But yeah, the new lighting technologies make a world of difference, I think.
Yes, and I just saw a question come up, which was, were the noise levels or light levels measured in each facility to see how the actual differences compare to the response? And the answer to that is no. But that would be a fantastic thing then to be able to do in regards to these measures that we have seen. So thank you. Did you want to talk about this at all regarding the acoustics, Richard?
Unless someone has a burning question, but what it did show here, that's a difference with acoustics between the minimum and moderate, there was no difference. But again, in comprehensive, it's just very different than the others, and it's again the amount of variation being explained is quite a lot. So when you have just a little bit of changes to affect acoustics, it didn't make a difference in productivity. But when you went fully locked and loaded on the comprehensive, it did make a difference in productivity.
And I will say that from an interior perspective, there was great consideration given to acoustics, from the softening to the carpeting. Pretty much everything was done with acoustics in mind.
Well, it seemed to work. Here again, we see that in looking at productivity, the QWB score does not track as the percentages in the on the IEQ score. We see, in fact, that a tendency for the QWB score to decrease when the people are completely satisfied. That says their productivity is completely enhanced by the color and textures and the finishes. And two things about this. This is a cross-sectional study, so we cannot say that that there's a causation between the two the differences between the two scores that we see. But we could speculate that when you're in an environment where you're completely satisfied with the enhancement, you work hard, and the objective measure of their health-related quality of life, you can say you're more tired. You work harder, but you're more tired. That's an interpretation that you can take away from this slide. Rather than, and it's an association and a correlation, but we're not saying that there's causation here.
So what does this mean? I mean, I think you'd like to sum it all up and everything we've been talking about. When we were looking at our findings, and we were actually sitting in a coffee shop, and I said, oh my goodness, well, this is just go big or go home. And so we've kept it. But really what we mean by that is, we talked about the difference in dollar per square foot, especially between comprehensive and moderate. And what we really found from this pilot study is that doing a moderate amount of enhancements just doesn't do the same thing. And so when given an opportunity, I do think it's really important as designers and as owners of facilities to understand that the more that you can put in will have a significant impact on your staff. And then as well, assuming that the model be correct, the conceptual model as well then is onto your patients.
And as you mentioned, sorry, I just lost it in my train of thought. Something about, I don't know, we'll come back to it if I think of it again.
You let me know if you think, and we'll keep going. So from a design perspective, let's just talk about a few things that we can tell you. So I think one of the things would be, from a design perspective, when we have this kind of data, it does help us to begin to, when we're making decisions on what to keep, what to put in, what not to put in, right? And so the top three things that we can tell from this study anyway, in regards to when you're looking to design for staff satisfaction, would be, number one, natural light. And I think we have plenty of evidence that supports that as well. Color, texture, and finishes, and ease of communication with colleagues. So those three things are really important, I think, for focusing on when looking at designing within the ambulatory care space. And when we talk about perceived productivity, that became very interesting because the top four things that we pulled out from that information, number one, speech privacy. So it goes back to the acoustics. Number two, color, texture, and finishes. Number three, the electric light. And number four, acoustics overall. And so I think when we begin to merge those results, I think what was maybe a little surprising to us is that, hands down, the cheapest thing you can do to make the greatest difference when it comes to satisfaction and perceived productivity is put paint on the walls. It's the easiest, cheapest thing you can do. And so I think in that regard, don't be afraid of color, and to understand that staff really do appreciate that in their area as well. So to not just think of color and texture and finishes in regards to just what the patients are going to see or what's visually impacting right when you walk in the door at first.
Now, we have a question come in real quick asking just, did you consider that color and texture appear differently in natural versus artificial lighting? But I suspect you probably weren't able to tease that out of the data, correct?
No. And I have to tell you, we so would love the opportunity to be able to tease some of that out of this data. We just didn't, we didn't have the counts. We really did this as a pilot to say, could we do it? But I think all of these things are things we would like to be able to consider. And I think another thing to really mention maybe at this juncture is how we looked at features. In theory, we would have loved to have been able to identify individual features specifically within the sites themselves. However, especially in the term of MESA, when I said everything's just all in there together, we realized that was going to be very difficult to do. And so that's why we did it based on level of enhancements. But again, wouldn't it be nice to be able to just do it specifically feature by feature?
And also,
you would probably need a much bigger sample size, right, to make that useful.
Yes,
and much more funding than weekends, holidays, and everything else.
And to do, you're absolutely right. To test the QWB, 30 respondents were fine. Having 30 respondents fine for testing it, and we showed that here. But to looking at a greater level of granularity, finer granularity, that was a drawback of the study, having 30 people. So we could test it overall, but we couldn't look in depth. Also, we married it to the IEQ, so we have to use the questions that they were put forth in the IEQ. So things like measuring the actual light levels, we actually were getting how the people responded on the IEQ rather than the objective measure using instruments to measure the light levels and the noise level.
Mm-hmm.
And then, I think, on that slide, the other thing was just to really note that perceived productivity is not necessarily synonymous with satisfaction. So I think to kind of sum it all up, yes, it is possible. Would we like to do more? Absolutely. We can tell you that design features do impact the health-related quality of life for staff. I think from a design perspective, being able to determine what we put in based upon evaluating those features based upon contribution is important. And I think really being able to dial down further, again, like we said, we'd like to explore that conceptual framework a little bit more and being able to really maybe fully understand the implications of staff health-related quality of life on patients. And where all of this study leads is for us to be able to now begin to put a cost associated with that health-related quality of life. And do you want to talk a little bit about that, Richard?
No, that was exactly that was a comment I was chomping at the bit to state. From the literature, we knew, the literature is replete with examples and of clinical outcomes of even the early work by Ulrich, and where you have shorter times of stay in the hospitals, less pain medication, but those hadn't been linked to a quantifiable measure like the QWB scale, where we can use of course, shorter length of stay and less pain medication. They are good clinical outcome measures and strong clinical outcome measures to use, but they tend to be somewhat blunt, because you can have a shorter length of stay and the person really is not feeling well, they just needed to go home. And you can have a fewer pain medication because people were stoic. But using a fine-grained scientific instrument like the Quality of Well-Being Scale, you can actually measure it and look for the cost-effectiveness of it. And we suspect, from what is suggested by the results we hear of this pilot, that you can attribute it to different features that where you spend evidence-based enhancements, evidence-based design enhancements.
We'll definitely be looking forward to that study.
in process, right? I do have a question that came up here, and it was, is there any input on the specific color and its effect on staff? And the answer to that is no. What I can tell you qualitatively is that staff haven't really commented on whether necessarily they like the finishes as much as the fact that they are there. So qualitatively, I've yet to have a staff member say, oh, I'm so glad you picked blue, or I'm so glad you picked red. But they all say, I love how it feels. And in MESA, interestingly, we did more of a living room style. So each department not only has its own color scheme, but it has its own artwork that is seen throughout, its own style of artwork. And it all coordinates. It's all beautifully coordinated, but each room has kind of its own feel. And the staff love their living room. They'll tell you about the artwork and how much they love it and how they like their color scheme or whatever. So that's been really fun and interesting, but I don't have any quantitative data regarding that.
And I just want to, do y'all remember that, gosh, I don't know, a long time ago, it came out that pink, I think was associated with reduced violence, and people were painting prison walls, pink like crazy. So, we do have to look at the patterns that we see throughout various research studies rather than being able, looking at just three examples, specifically.
Sheila, I have a question for you. Are these slides available to everyone after this conversation?
Yes, they are. So
Great.
If you go up in the upper right, it's Show My Media Library, and you can download the slides there.
Great, because I have a question, in which was, what are the color schemes used? So all of the interior photos that you see in this presentation are actually from Mesa. So that beautiful photo of the soffit is going to kind of show you the color scheme. But the color scheme was really based upon the geography in Arizona. So you're going to see kind of a burnt red, somewhat of a sand color, a little deeper color, kind of the reddish sandy color from the mountains, and then a sage green, really representing really more the agave plant, and then also some inferences from water. So there's a little bluish theme running through. But I think if you look at the photos that are in this deck, it definitely shows some of those interiors. And then, one of the things early on with patient satisfaction surveys we did find out is that in the OB, they tend to like the color purple. So we have different shades of a real beautiful kind of sunset shade of purple in the different OBs, and the color schemes are different for Mesa and for Surprise, but they have a lot of similarities as well.
Well, thank you both so much. We are just about out of time. This was really a very, very interesting discussion, and I can't thank you enough. Let's just a little bit of a housekeeping here. Want to remind folks, if I can click the right button. There we go. This is a question and answer. Sorry, I should have done that sooner. Sorry. I moved my cursor. Okay. Here we go. Just a reminder on the CEUs. There are both EDAC and AIA CEUs available. Download the additional information from that Show My Media Library icon. You will need to complete the verification form for the EDAC CEU and keep that for your own records when you need to share that with Castle Worldwide. And for the AIA, you need to complete the CEU verification form and quiz, and also purchase a CEU management fee from the Center for Health Design. I just want to remind everyone that this event is brought to you at no cost to you by the Center for Health Design, and we want to thank the HERD Journal for providing free access to the articles that we typically review in the Journal Club sessions. If you haven't already done so, we do recommend subscribing to HERD. And just a special thanks to both of our authors here today, Deborah and Richard. Thank you so much.
Very
welcome. It was a joy to be here. And please, if there are any further questions, do not hesitate to reach out to one of us via email or LinkedIn or however you'd like to do it. We are more than happy to answer any questions.
Great. Thank you.
Thank you.